Hi guys, this is Jody, and this presentation will cover part 2 of the coronary artery disease exemplar, which is under the concept of perfusion. So please use your textbook as a resource for this topic as well. And what we're going to start with is clinical manifestations. So it's important for you to know that you can be working in any clinical setting. Could be that you're working in home care, or you're working in a doctor's office, or you're working on any type of unit in the hospital, and you could have a client who is having a myocardial infarction. So it's very important for you to recognize these symptoms, because myocardial infarction is often the first sign of coronary artery disease. So a client could be coming into the hospital, with a broken hip, and end up having an MI. And that has happened. And I've taken care of those patients that end up coming into the cardiac unit after that happens. So recognizing the clinical manifestations, recognizing if a client is at risk for myocardial infarction is important, and then teaching prevention to all clients regardless of the clinical setting. So you will discuss more about dysrhythmias in 222, but you should be able to recognize if a client is having is having an ST elevated MI. Okay, so we will talk more about pump failure and heart failure symptoms later in the semester as you guys talk about that heart failure exemplar. And then in this presentation, we will briefly discuss pericarditis and Dressler syndrome. So with clinical manifestations, you're going to see the angina, which is the chest pain associated with the heart. And that chest pain is generally substernal, so right behind the sternum, right where the heart sits. But it can radiate up to the neck, arms, shoulders, jaw. The telltale symptoms are chest pain that radiates down the left arm. It's usually precipitated by cold or activity. Okay, relieved with rest or nitroglycerin. This is important to know, okay? So if you have a client that has chest pain that's related to trauma, like maybe they were in a car accident, they have musculoskeletal damage in their chest and they have pain, you can treat that with Tylenol or ibuprofen or opioids. That's going to help that pain. If you have a client who has chest pain that is related to the heart, okay, this is truly angina, then what we need to do is have that client rest. So it would be bed rest, sit down and rest, because that takes workload away from the heart. And the other thing we can do if the rest alone doesn't help with chest pain is give them some nitroglycerin, because that vasodilates and it gives a wider passage for the blood flow to get to that heart muscle. Okay, with angina, it generally doesn't last long. If you have a client who has pain at rest, okay, they develop this chest pain at rest, they're not doing anything but sitting in a chair or a bed, and they develop it and it lasts somewhere a little bit longer, between 10 to 20 minutes, it can last up until, then we characterize that as acute coronary syndrome. So this means now that they have developed this, decreased perfusion overall of the heart, okay? Acute myocardial infarction means now there's part of that heart muscle that is not getting the blood flow that it needs. We're going to end up seeing some tissue death if we don't react quickly. And the symptoms of an MI are angina, dysrhythmias, heart failure symptoms, pericarditis, and Dressler syndrome. Now, it is important to note that you can have people have silent MIs, which means they really don't have the chest pain. This can occur especially with diabetics. They may not get the telltale chest pain, crushing elephant sitting on my chest, I can't breathe symptoms. Okay, you can have people have silent MIs, but you need to recognize that if somebody is all of a sudden becoming short of breath, they're having this, chest pain, you're seeing some dysrhythmias, we need to react, okay? So, and we'll talk about that a little bit more in one of the next slides. When we talk about pericarditis is inflammation of the pericardial tissue that surrounds the heart. So if you know that pericardial sac, there's some fluid in there that gives some cushion to the heart as it beats. It is something that can occur outside of an MI, okay? So you can have somebody in a hospital with pericarditis that might be related to like a virus or something like that. It's not always associated with an MI, but it can be a complication of an MI or a complication of a procedure like an angioplasty or coronary artery bypass graft, okay? You can recognize pericarditis with symptoms, okay? The typical symptoms of pericarditis are pain in that chest, okay, right where the heart sits. It can be aching, sharp, or stabbing pain, but it is usually worse on inspiration. So if you tell or ask your client to take a deep breath and they say, oh yes, that it hurts worse when I take a deep breath, that is a telltale sign, okay, of pericarditis. So if you think about the lungs expanding when we take a deep breath, what the lungs are going to do is going to push that heart forward during inspiration, and is going to push the heart up against the sternum. And if that sternum is inflamed, it's going to be painful as it pushes up against that sternum. Okay, as it is inflamed, as it does push up towards that sternum, you can hear a friction rub when you're listening to the client's heart sounds. Okay, so telltale signs for the pericarditis are going to be chest pain that is worse on inspiration, and that pericardial friction rub that you can hear when you're auscultating the heart sounds. Okay, it's often treated with anti-inflammatory medications like ibuprofen. Okay, so you might be giving your patient ibuprofen kind of around the clock every 6 hours. If it's real severe, they can go with corticosteroids. Okay, if it's really, really bad, what they can do is actually stick a needle in and aspirate some of that fluid. Okay, that's a pericardial synthesis. So to listen to that, you have to know, obviously, normal heart sounds first. So if you listen to normal heart sounds, you get the lub-dub. Okay, lub-dub, lub-dub, lub-dub. As you hear a friction rub, it's going to sound a little bit more fluid-like, and you'll hear that kind of rubbing sound as it's pushing up against that sternum. And these were really the best sounds that I could find. As you listen to it live with a patient that actually has pericarditis, that friction rub is pretty distinctive. So I think you guys would definitely pick up on it because it does sound very different. So the best thing for you guys to do in clinical is, let your preceptors know, let your nursing instructor know in the first couple weeks, or really throughout the whole clinical experience that you have left. If you have clients with abnormal heart sounds, you want to get in there and you want to listen to those. All right, we go to the next slide here, maybe. My thing is not cooperating with me. Hold on one second. Okay, go to the next slide. So we'll talk about Dressler syndrome. So Dressler, it is thought to be an autoimmune response. It may reoccur over several months after a client has a myocardial infarction, and it generally resolves on its own. Okay, it is characterized by fever, chest pain, and dyspnea, and it does involve some pericarditis, so you might hear that friction rub. Okay, so it's just kind of this general overall symptoms that they have over a long period of time. Obviously, if you have somebody who's having chest pain after an MI, they're going to take a look at that patient, work them up, and do that whole thing. But if they kind of see that the patient's having these symptoms along with that fever, then they can look at this as being like a Dressler syndrome. So when perfusion is impaired, I want you to think outside the box, and the fact that I want you to think outside the heart into the rest of the body. So this is just a reminder that the heart impacts the rest of the body. The heart is the pump that provides the blood and the nutrients and the oxygen to the rest of the body. So if the heart is not working properly, it may not be perfusing effectively, which is going to limit the blood supply to tissues in the body. So the skin may feel cool and or appear pale. Capillary refill time may be prolonged because it will take longer for the blood to travel. The brain requires a lot of blood, so if it's not perfused properly, we may see a change in level of consciousness. The client may be lethargic, or we could see some confusion. Okay, if perfusion is impaired over a long period of time, we can also see a decline in kidney function because the kidneys aren't getting the blood, oxygen, and nutrients that they need. So collaboration. So what are our goals for this patient? We want to teach smoking cessation. We want to manage blood pressure. We want to strive for a healthy BMI, manage cholesterol and diabetes, encourage activity. The activity that the American Heart Association recommends is 30 minutes a day, 5 times a week. Okay, we want to teach stress management, provide diet teaching. So what do we want them eating? We want them eating a heart healthy diet, which includes fruits and vegetables, lean protein that's low in saturated fats, and increase in fiber. We want them to kind of not eliminate salt, but eat low sodium foods. So pay attention to women, especially who have risk factors and are taking oral contraceptives. So again, you can have women in their 20s, 30s, 40s that aren't typically the age that you would look at risk for a myocardial infarction or heart disease. But if they are on oral contraceptives and say they smoke and they're obese and they have a family history, you kind of have to paint this picture of this individual to say, oh boy, you already have these increased, risk factors for heart disease. And now you've just thrown on an oral contraceptive, which does increase risk for blood clots. Okay, so that increases the risk for heart attack and stroke. Okay, so, we'll talk a little bit. I'm not going to do the video of rapid response here for MI, but we will demonstrate that a little bit in class as we talk about in class. But if you think about, the collaborative efforts, think about rapid response. So I don't know if you guys have ever seen rapid response in your clinical settings, but there is generally a team in the hospital that will come in and help you manage a client who is having an active MI. Okay, because we need emergent, immediate action if a client is having chest pain. We think they're having an MI, especially if we do that EKG, they're having an ST elevated MI. We see that on the EKG. We need to get a rapid response going so that we can get that patient to the cath lab and get reperfusion to that heart muscle. So there is a lot of collaboration in that as well, as in managing that emergent situation. So I will get a video that we can watch in class of that rapid response. So diagnostic tests. The big ones here are the ones that I have highlighted. C-reactive protein is just going to be looking at overall inflammation in the body. So EKG. EKG is going to be the one. If you have a client that comes in to the hospital or a client on your unit that develops chest pain, generally the first thing that they're going to be ordering is an EKG. So the more you can be prepared to do that, the faster you can get that going on, that is great. You want that EKG because you want to see, is that patient in a normal rhythm, or are they having a dysrhythmia, or are they having an ST elevated MI, which requires immediate action. An exercise EKG would be done outpatient generally. This is if a patient, maybe has some risk factors for heart. Maybe they've had some chest pain here and there, but they're young and fairly healthy, and we can get them on a treadmill and we can, get that heart pumping and working and that heart rate up a little bit and see what the heart does. Then they're recording to see, are there changes in that heart as that heart rate goes up and they're exerting themselves. A CK and a CKMB also indicates some damage in the body to muscle, but the troponin is the key to cardiac muscle damage. So troponin is generally going to be the one that you are doing every 8 hours, 3 times to see if it's elevated. Now I have on here find normal troponin levels because I'm trying to see what your book calls. It has the troponin T and the troponin I think. So I just, am going to look, and I will let you guys know in class what we will be looking at for the troponin level. Generally, what I'm going to say at this point is if it's 0.04 or less, it will be negative for an MI. If it's 0.04 or greater, it is going to be that they're going to say, yes, there's some cardiac damage. Now, you can have a patient who has positive troponins if they have something called rhabdomyolysis, where they come in. So you have a client who, I've seen this in practice several times, if you have somebody who falls and has a lot of muscle damage or has been in a huge trauma and they have this overall muscle damage that's gone on in the body, they can have that elevated troponin level. But troponin, other than like rhabdo, is generally specific very much for an MI. Cholesterol screening. So I want you guys to look at that document that I gave you. I did give you some cholesterol screening information for your prep. So take a look at that. You should know what those levels are for cholesterol. Echocardiogram is the other one that they will do. This is the ultrasound of the heart. Okay, so that they can look at kind of blood flow and perfusion of the heart. This is going to be one that they definitely do if they're suspecting some heart failure. And then there's hemodynamic monitoring, which you'll likely talk more about in 222. So conservative management. Conservative management is going to target the modifiable risk factors. So if the client smokes, we're going to be teaching smoking cessation. We're going to look at their diet. If they have a high BMI or an unhealthy diet where they're eating, maybe they're eating fast food very frequently, we're going to look at modifying their diet. Exercise. If they're not somebody who is regularly exercising, we are going to instruct them on the American Heart Association recommendation of 30 minutes a day, at least 5 times a week. Hypertension. So if they're hypertensive, we want to manage their hypertension. And if they're diabetic, we want to make sure that their diabetic is well controlled. So that is conservative management. This means we're not throwing a lot of treatments at them right away. Right away, we're targeting their risk factors. Okay, so smoking. Smoking cessation reduces the risk by 50% within a year of quitting, no matter how long they smoke. So that's important to know, because you'll have a lot of patients say to you, oh, I've smoked for, 20, 30, 40 years. I'm not going to quit now. The damage is done. Well, if they start making changes and they quit, they're going to significantly reduce their risk factor for heart attack. Okay. So what smoking does is it actually increases blood viscosity, which makes the blood thicker. So once they stop smoking, it actually reduces the blood viscosity. So it's going to be less likely to stick together. Those platelets are going to be less likely to stick together and form clots. Diet, again, low in saturated fats, high in fibers. So that's your fruits and vegetables, your oatmeal, stuff like that. High protein, high fat diets are not recommended for clients with a risk of heart for CAD. So think about, right now a huge trend out there is the keto diet. And you'll see some patients, or some individuals, and I'm not saying everybody who follows keto is eating really, really, really bad, but generally they're eating, a lot of eggs, a lot of meat, and those are generally going to be high in saturated fats. So we really want to, we would not recommend that to a client. Now, there is the South Beach diet that's out there that was actually written out by a cardiologist, and the proteins that he has in that are really healthier proteins. It's going to be a lot of fish and a lot of vegetables is what you're going to see in that. So, I'll say never, never, but you're really not going to do a high protein, high fat diet for somebody who has CAD or really at risk for CAD. So we want them to avoid high sodium foods, limit their alcohol consumption, and weight loss through healthy diet and exercise. So exercise, again, 30 minutes, 5 to 6 days of moderate intensity every week. Okay, so if they tell you, well, I get up and walk to the bathroom a few times a day, it probably adds up to 30 minutes. No, this is 30 minutes of continuous getting that heart rate up exercise. So it could be going out for a brisk walk. If there's somebody who never walks, they can just go out, and walk at whatever pace. They're probably going to get their heart rate up pretty quickly if they don't exercise very often. But it's 30 minutes of moderate intensity, getting that heart rate up for a continuous 30 minutes, 5 to 6 times a week. For weight loss in somebody who doesn't have any major heart history, they would say 60 to 90 minutes, that 5 to 6 days a week for moderate intensity. And actually, you could do it up to daily. Manage hypertension. So to manage hypertension, we're going to look at their medications. Lisinopril is generally the first medication, or ACE inhibitors, I should say, are going to be the first medications that they prescribe for hypertension. Now, you will have some clients who cannot tolerate the ACE inhibitors because of that dry cough that some people get, but it's generally the one that they like to go for first is the ACE inhibitor. They can also reduce their sodium intake, because the more sodium we take in, the more fluid we hold on to, because we always have to maintain a sodium, a specific 135 to 145 sodium level in our blood, right? So if we take in a lot of sodium, to balance that, your body is going to hold on to more fluid in the vascular system. Well, that gives the heart more blood, more volume to have to pump around. That's more workload on the heart. So to reduce blood pressure, sometimes we will do a very low sodium diet with those clients. Stress management takes, really, I mean, think about it with yourself, relaxation techniques, doing some deep breathing or meditation that lowers that heart rate, puts us more in a relaxed state, will lower the blood pressure. And then again, taking those medications as prescribed. And then diabetic management, making sure that they're checking their blood pressure regularly. If there's somebody who, diabetes was really managed through diet and they don't check their blood sugars regularly, they should be having their A1C checked every few months to make sure that, they're maintaining, a healthy level on their blood sugars on a regular basis. And then take meds as prescribed. Okay, so pharmacology. I know I gave you a huge list of medications for perfusion to look at. So know that many meds treat the risk factors, which is cholesterol and blood pressure, and you need to know these, okay? Drugs to treat angina, so your nitrates, your beta blockers, and your calcium channel blockers. Those are going to be really important. So really looking through those medications. Now, when you go through and you fill out the medication chart that I gave you, don't dig down and try to write every specific thing that can happen with the medication. You really not want to know what the class of the medication is. Is it a vasodilator? Is it a beta blocker? What are those meds going to do to the patient? What do you need to monitor? Okay, so like for instance, with nitroglycerin, you give that to a client, it's going to vasodilate. Before you give it, you want to make sure that their blood pressure is not, really, really low, because that nitroglycerin is going to drop their blood pressure. So you would monitor their blood pressure. You give the medication for chest pain. You want to be monitoring their pain. You're going to be monitoring the blood pressure after you give the medication. You would be instructing the client, after they take the medication, not to get up real fast, because they can have that drop in blood pressure. So think about your nursing interventions for the medications, but don't go really deep into the meds. It's going to be more, that surface stuff, the main stuff that's going on. Why are we giving it? What do we need to assess for when we give it? What are the side effects, that type of thing. So again, we'll talk about student learning outcomes. These are your student learning outcomes for the CAD exemplar. So please look at the student learning outcomes as you're going through and studying and looking through your resources. And I think I said it in the previous presentation, but if I didn't, I'll say it again, that your book is a resource, okay? It is not a novel, so it is not, it's not something that should be read from beginning to end, okay? I would say look at your student learning outcomes, plan health promotional strategies that offer optimal perfusion for this patient. So look at that section of the resource and kind of go through and study and get the information for that student learning outcome, okay? And then you might consider the pathophysiology and the risk factors, the clinical manifestations. So look at those sections of the textbook. So that is how you should be utilizing your text. It's a resource. It's not a fictional novel that's going to be entertaining that you're going to read from, first page to the last page. If you do that, you're probably going to forget everything you read. Okay, so focus in on your student learning outcomes. Utilize these presentations. Please, please, please ask me questions if you have them. Bring questions to class. I will be happy to answer them. And as always, if you need to, set up office hours and that, I'm more than happy to meet with you. Okay, so I will see you guys in class. Thanks.